Every 66 seconds. That's how often someone in this country is diagnosed with dementia. Not every hour, not every few minutes. Every 66 seconds. By the time this video ends, dozens more people will have been told that their memories, their stories, their grandchildren's names are beginning to fade. And here is the part that no one is telling you. For many of those people, the cause isn't simply aging. It's sitting right now in their medicine cabinet, in the nightstand drawer, in the little orange bottles they take every single day without question. Stay with me, because what I'm about to share could be the most important thing you hear this year about your brain. And number one on this list stunned me when I first discovered it. I'm saving that for last. I'm not here to scare you into throwing away your prescriptions. I'm here to give you the information that your 15-minute doctor's appointment never had time for. There are 9 specific medications, some sold without a prescription. Some prescribed for conditions that have nothing to do with your brain, linked scientifically to memory loss, cognitive decline, and a meaningfully higher risk of dementia. Most people taking them have no idea. Most doctors, not because they're careless, but because the system doesn't allow it, have never connected these dots with their patients. Today we're connecting them. If you take regular medication, or love someone who does, stay all the way through. Because number 1 isn't what you expect. Let's start at number 9. And notice something as we go. These medications aren't unrelated to each other. Each one attacks the same underlying brain chemistry. By the time we reach number 1, you'll see exactly how these threads weave into something far more dangerous than any single pill alone. Number 9 is diphenhydramine. You know it as Benadryl, or as Zysquil, Unisom, Tylenol PM, Advil PM, the most widely used over-the-counter sleep aid in the world. Sitting on shelves in every gas station and pharmacy in America. Millions of older adults take it regularly, some every night. It feels safe because no prescription is needed. How dangerous could it be? Here is what the packaging doesn't say clearly enough. Diphenhydramine belongs to a class called anticholinergics. Your brain runs on a chemical called acetylcholine, central to memory formation, learning, and focus. Anticholinergic drugs block acetylcholine. They put a roadblock on your brain's memory highway. A landmark study in JAMA Internal Medicine in 2015 found that people who used drugs like diphenhydramine regularly over months and years had a significantly higher risk of developing dementia. Not a small blip, a real documented increase. And yet the box says, take as needed, with no mention of long-term cognitive risk. That's number 9. Hold on, because number 8 involves something that tens of millions of Americans swallow with their morning coffee every single day, and have been swallowing for years without knowing this. Number 8. Proton pump inhibitors. Omeprazole, Prilosec, Nexium, Pantoprazole. Prescribed and sold over the counter for acid reflux, heartburn, and stomach protection. They work, the burning stops. You feel better. The problem isn't what they do for your stomach. It's what long-term use does quietly to your brain. Your body needs stomach acid to absorb vitamin B12. B12 is required for the protective myelin coating on your nerve cells and for neurotransmitter production, tied to mood, focus, and memory. Suppress stomach acid for months or years, and B12 absorption drops. Blood levels fall, and severe B12 deficiency doesn't feel like a stomach problem. It feels like confusion, brain fog, forgetting words mid-sentence. It can mimic early Alzheimer's disease closely enough that patients have been misdiagnosed. Here is the crucial difference. Unlike true Alzheimer's, B12 deficiency-related cognitive decline is often completely reversible if caught in time. Let me say that again. The memory problems caused by this can be reversed, but only if someone thinks to check. How many people right now are being monitored for early dementia when the real cause is a pill they take every morning? If you or someone you love takes a PPI daily, Pause this right now and write this down. At your next appointment, ask for a B12 blood level test. Simple, inexpensive, potentially life-changing. Go ahead, I'll wait. And if you're finding this valuable, hit that like button. It helps this reach the families who need it most. Number 7 is one people feel uncomfortable discussing because it's prescribed for a personal problem. Oxybutynin, sometimes sold as ditropin, is among the most commonly prescribed medications for overactive bladder. For older adults who have quietly reshaped their lives around bathroom access, it can feel like a miracle. And I understand that. But here is what the prescription label doesn't highlight. Oxybutynin is a potent anticholinergic, and this one has a particularly troubling ability. It crosses the blood-brain barrier. That protective wall, your body built to keep harmful substances out of your brain tissue, oxybutynin gets through it. Once inside, it blocks acetylcholine directly in the brain regions, responsible for memory. A major study in the BMJ in 2019 confirmed what neurologists had been observing for years. This drug class is directly associated with cognitive decline in older adults. The important thing, safer alternatives exist. Newer bladder medications don't penetrate the brain barrier nearly as readily. Your doctor may simply be prescribing oxybutynin out of decades of habit. You are allowed to ask about alternatives. You deserve to know they exist. Write this one down. Now number 6 hits close to home for millions of older adults, because it's about the pill they rely on every single night just to sleep. Number 6. Z drugs. Specifically, zolpidem, sold as Ambien. Sleep problems are among the most common complaints for adults over 60. The doctor writes the prescription. 1 pill. A full night's rest. Reasonable enough, right? Except here is what happens in an older brain that the commercials never show. In a younger adult, zolpidem clears from the bloodstream in a few hours. In an older body, that process is much slower. The drug lingers. Active levels in the brain stay elevated long past when they should have tapered. Chronically, zolpidem slows the brain's processing speed and impairs anterograde memory formation, meaning the ability to form new memories after the drug enters your system. People wake up with no recollection of conversations they had or calls they made during the night. And there's a second risk that deserves more attention: falls. Zolpidem dramatically increases fall risk in older adults. A broken hip for someone over 70 is not a minor event. It can trigger a cascade of complications that fundamentally changes a life. If you know someone over 65 who takes Ambien regularly and has had an unexplained fall or episode of confusion, share this video with them. They need to know. That brings us to number 5, and this one I'll approach with particular care because many people depend on it for very real relief. Number 5. Benzodiazepines. Xanax, Valium, Ativan, Klonopin. Prescribed for anxiety and insomnia. For someone in genuine crisis, they can provide meaningful relief, and I'm not dismissing that. But the American Geriatric Society's Beers criteria, the gold standard reference for medication safety in older adults, explicitly places benzodiazepines on the list of drugs to avoid for people over 65. Here's why. These drugs amplify a brain chemical called GABA, slowing neural activity and creating calm. Short-term in a crisis? Sometimes appropriate. Use them for more than 3 months, which is exactly how most people end up using them, and the brain adapts to the constant chemical sedation. It starts operating at a lower baseline alertness. Word retrieval slows. Memory recall slows. Reaction time slows. It creeps in so gradually that nobody notices until someone compares a video from 2 years ago to today and is startled by the difference. Neurologists call this cognitive sedation creep. Stopping abruptly is dangerous, always under medical supervision. If you've been on a benzodiazepine for more than 3 months without discussing long-term cognitive risk with your doctor, that conversation is overdue. Not someday, soon. Number 4 is a medication many people take for pain, nerve problems, or sleep, without understanding what it does at the brain chemistry level. Amitriptyline, originally developed as an antidepressant decades ago. Today prescribed in small doses for neuropathic pain, migraines, and insomnia. Physicians often describe it as just a small amount of a very old medication. That phrasing sounds reassuring. Here is what it doesn't tell you. Even at a small dose, even the tiny dose used just for sleep, amitriptyline carries one of the heaviest anticholinergic burdens of any drug in regular use, and has been shown to produce measurable erosion in short-term memory over time. The effect is cumulative, week after week, month after month. And many people taking amitriptyline are also taking 1 or 2 other anticholinergic medications, perhaps oxybutynin for the bladder, perhaps Benadryl on rough nights. The combined effect is something fundamentally more dangerous than any one drug alone. We're almost at number 1. And what's waiting there is going to reframe everything you've heard so far. Number 3. Challenges an assumption many people hold about antidepressants, that because they're in the same general category, they carry roughly equivalent risks. Not true. SSRIs like sertraline and escitalopram are generally well tolerated in older adults with low anticholinergic activity. Paroxetine Paxil is a different story. Despite being in the same drug family, paroxetine carries significant anticholinergic properties its cousins lack. Studies examining it, specifically in older adults, have documented impairment in short-term memory, the kind that holds a thought mid-conversation, remembers why you walked into a room, pulls up a word that was right on the tip of your tongue. These losses get quietly attributed to just getting older. They are not always aging. Sometimes they are a specific pharmacological side effect, one that could be addressed by switching to a safer antidepressant while keeping the same benefit. If you or someone you love takes Paxil, this is worth raising at the next appointment. And while you're thinking about that, drop a comment below right now. Which medication on this list surprised you most? I read every comment. Your responses help me understand what's actually reaching people and what to cover next. Number 2 makes me angry every time I think about it. Quetiapine, Seroquel, an antipsychotic with FDA approval for serious psychiatric conditions. Schizophrenia, bipolar disorder, severe depression. A powerful drug built for serious illness. And yet, over the past 2 decades, a disturbing pattern has spread across nursing facilities and outpatient settings. Quetiapine is being routinely prescribed off-label for purposes it was never approved for, without adequate safety evidence, to elderly patients as a sedative. A restless older adult keeps staff up. A caregiver is exhausted. Someone writes a prescription for just a little Seroquel to help them settle. Here is what actually happens in that brain. Quetiapine suppresses dopamine, the neurotransmitter responsible for alertness, sharpness, curiosity, and personality engagement with the world. Someone who is mentally vibrant before starting this can become noticeably slower, flatter, more disconnected within weeks. The family sees it and assumes the disease is progressing. The medical team notes it and attributes it to age. Almost no one asks whether the new pill is responsible. If you have a family member in a care facility and have noticed a meaningful change in their mental engagement since a new medication appeared, you have the right to ask what it is, why it was prescribed, and whether a safer option exists. Ask, insist on an answer. And now, number 1. This is what I've been building toward, and the first thing you need to understand is that it is not a single medication. What sits at the top of this list is happening right now in tens of millions of homes, completely invisible to the people living in them. It is called anticholinergic polypharmacy. Let me show you what it looks like in real life. Picture a woman, let's call her Dorothy, 74 years old. Seasonal allergies. Her family doctor suggested Benadryl. Overactive bladder. Her gynecologist prescribed oxybutynin. Trouble sleeping. Her primary care physician started her on low-dose amitriptyline, 3 medications. 3 different doctors who don't share records and have never reviewed her full list together. Dorothy doesn't think of herself as someone who takes a lot of medication. She has 3 small, separate, manageable problems. Here is what is actually happening in her brain. Benadryl blocks acetylcholine. Oxybutynin blocks acetylcholine and crosses into her brain tissue directly to do it. Amitriptyline blocks acetylcholine. These effects don't simply add up, they amplify each other. A major analysis in Age and Aging in 2022 found that people with the highest cumulative anticholinergic burden had more than double the risk of developing dementia compared to those with low burden. More than double. Not 10% higher. Not 20% higher. More than double. Dorothy doesn't know she's in that high-risk group. Not one of her 3 doctors has looked at her complete medication list and calculated her total anticholinergic burden. Because the healthcare system, as it operates today, is not designed for that kind of integrated review. Which means you have to be the one to ask for it. This is your most important takeaway. Before your next appointment, write down every medication you take, every prescription, every over-the-counter pill, every sleep aid, allergy tablet, antacid, everything. Bring that list to your doctor and use these words. I would like you to review my full medication list for total anticholinergic burden. It is a validated clinical tool. Your doctor knows what it is. And it may be the single most important conversation you have this year for protecting your brain. Please do not walk away from this and immediately stop your medications. That would be the wrong response. And for some drugs, particularly benzodiazepines, stopping abruptly without supervision can be medically dangerous. The goal here is not panic. It is information that most people your age have never been given in plain language. You now have it. Use it to have a better, more specific conversation with your doctor. You are allowed to ask, is there a safer alternative? You are allowed to say, I want to understand my anticholinergic burden. A physician who cares about your long-term health will welcome that conversation. Your action plan: write out every medication you take, including over-the-counter ones. At your next appointment, ask specifically about anticholinergic burden. If you take PPIs daily, request a B12 blood level test. If a loved one is in a care facility, ask about any medications added in the last 6 months and whether they appear on the Beers criteria list. And remember, not all cognitive decline is inevitable. Some of what is happening to older brains right now is not the passage of time, it is chemistry. Chemistry can be reviewed, adjusted, and corrected when someone finally knows where to look. Your brain is worth fighting for. The research exists. The clinical tools exist. The safer alternatives exist. The only thing that has been missing is this conversation. You can have it at your very next appointment. If this video gave you something you didn't walk in with, hit that like button right now. 1 second of your time tells this platform to put this in front of other families who need it. The adult child who noticed their mother seems different this year and doesn't know why. The spouse who is quietly terrified by what they're watching. Leave a comment. Which number surprised you most? Was it the B12 connection at number 8? The combination at number 1 that doubles dementia risk? Tell me below. I read every comment. And if you haven't subscribed yet, please do it right now, because next week, I'm covering the truth about brain health supplements marketed to older adults. What the science actually shows versus what the marketing claims. And which popular products may be doing nothing while real risks go completely unaddressed. You don't want to miss that. I'll see you then. Take care of your brain. It's the only one you have.